So welcome everyone to today's session. My name is Sally Leech. I'm from Henpicked and Henpicked Menopause in the Workplace. I'm really delighted to be with you all again today and delighted to welcome back Dr. Clare Spencer from My Menopause Centre. And today we're going to be talking all about menopause and depression. So welcome, Clare, and thank you for joining us.
No, thank you so much for having me. It's lovely to be here again.
Fantastic. So we just thought we'd start off today's session with just talking about what do we mean by depression and what are the typical symptoms someone could be experiencing?
Yes, hi, thank you. Great question. Because in reality, we use the term depression to mean a wide range of feelings and sort of all up to the point of just feeling a bit sad, just feeling a bit low and a bit blue, up right onto the end of the spectrum that includes sort of major depressive illness, where the mood is so low, persistently low, that it significantly interferes with function. So it's a term that is used widely, but if we think about medically what it really means, if I read out some of the symptoms, you'll see there's a massive overlap between symptoms of the menopause. And it does really, it's that degree of how much it interferes with function that is important to sort of how we define it. So depression is really defined as being persistently sad or experiencing a low mood nearly every day, with loss of interest or pleasure in most activities. So that persistent feelings, plus 3 or 4 of list of symptoms from a list that includes fatigue or loss of energy, feeling worthless with excessive or inappropriate guilt, sadly recurrent thoughts of suicide, of death, or actual even suicidal attempts, diminished ability to think or concentrate or increased indecision, sort of a psychomotor physical agitation or just really slowing down, pulling back, loss of the ability to sleep or sleeping too much, and change of appetite and weight changes. So, you know, if that's sort of a list from the official criteria for diagnosing depression, I mean, how many of those symptoms can you also tick with the menopause? So there's loads of overlap between the symptoms, aren't there?
Absolutely, and I think it's that confusion. We'll come on to that in a moment of how we identify what it is that's going on. So, and we recognise menopause can have a big impact on our mental health. We know depression can be listed as a symptom of menopause that can have a huge impact. Why do you think somebody may be experiencing this during their menopause journey? What might be going on that might be causing those feelings from a menopause point of view?
Yeah, so if we just focus for a moment on the menopause, we know that totally beyond their control, some women's brains are just more sensitive to changes in hormone levels and drop in hormone levels. So in the perimenopause, we've got big swings of hormones and a drop in estrogen. And then as we go through the menopause, the estrogen level is low and stays low. And so if we just focus on depression at the moment and not anxiety, we just consider anxiety separately, although the two can go hand in hand. So depression and that loss of that low mood can occur because the drop in estrogen can pull down the serotonin in your brain. That's a hormone in your brain that's the sort of happy hormone. That's oversimplification. There are other biochemical changes, but ultimately it's the hormonal change that results in the changes in chemicals in your brain that can then pull your mood down. And that's what's going on. But then when you put on top of that what might be going on in life, so you might be dealing with all the physical symptoms of the menopause, which can, we know, have an impact on your mood. You've also got work, potentially work stress. You've got what's going on at home in families with aging parents. So, and all of those external stressors, plus what's going on biochemically, plus physical symptoms, can all conspire really to pull your mood down.
Absolutely. And I think, again, we talk about this a lot when we're running our sessions around that cycle of symptoms, in terms of the physical symptoms can have a really big impact on your mood, or some of those psychological symptoms can then affect your sleep, which then can affect some of the physical symptoms. So I think it is this vicious circle that we can get into with symptoms. And how does someone identify if it's menopause or hormonal changes that are causing feelings of depression, or all those other things that are going on, or the changes in the body? Because I think that's where a lot of the questions we get from people is, how do I know, is this menopause causing this, or is it something else?
Yes, and in reality, it's really difficult to answer that, because there isn't one test that tells you that your mood is low because of the menopause or it's low because of depression, but there is an overlap and there are some clues. So as I said earlier, some women are more susceptible to those swings in hormones. And so women who've suffered through premenstrual syndrome or premenstrual dysphoric disorder, which is the more severe type of premenstrual syndrome, women who felt really good in pregnancy but then have postnatal depression, or women who felt more depressed in pregnancy, that can happen as well. They're all clues that you may struggle more with your mood as you go through the menopause transition. And also, it's also thinking about what else is happening. So sort of thinking about how symptoms have developed. Have they developed alongside other menopause transition symptoms, which gives you an indication it might be part and parcel of that picture of the menopause? And then it's really then due to function. And as I said right at the beginning, so major depression, proper horrible depression, is that loss of function or impaired function as a result of symptoms. So it's not black and white. It is more of a spectrum, and it's the number of symptoms, the severity of symptoms that would push you towards thinking, oh, this could be major depression. You can have major depressive symptoms as a result of the menopause, but you might manage them differently. And then it's the sort of story through life that would make you think more, right, okay, this sounds like it's more hormonally linked. It's really tricky, isn't it? Trying to tease it all out.
Absolutely. And I think it goes back to what we talk about with all menopause symptoms, keeping a really clear diary of what's going on for you and what's normal for you, and all of those things that are going on helps to build that picture. And it links really to the next question around, if someone has experienced depression throughout earlier life, is menopause likely to make it worse? Is it more likely to happen during menopause? Again, any thoughts around that?
Yes, sadly it does. So we know that if women have suffered from depression previously that may not have been anything linked to reproductive hormones or events, it is a bit more likely to come back in the menopause transition. It is something definitely to look out for and tell others to look out for also.
And in terms of approaches to how someone might manage this, so what kind of treatments might be available, or the approaches people should think about, things that can start to look at what they're experiencing and how they can maybe overcome some of those feelings?
Yes, really good question. So a huge range. And can I just say first that if you are experiencing suicidal thoughts, if there are thoughts of self-harm, if you can't get those thoughts out of your head, then please, 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 111 999 if it's really dreadful. There may be a crisis number that's local to you. So you must ask for help. See your GP. Don't leave those thoughts lingering. In terms of other general management, sort of like general menopause care, there is a wide range of approaches. So for some women, lifestyle changes will make all the difference. I love running, and for me that clears my head, that lifts my mood. And so there's the minor end of the spectrum. You may just be able to change lifestyle and really help those symptoms. For others, it will be meditation, it will be yoga, it will be alternative therapies. There is really, really, really good evidence that cognitive behavioral therapy can help with particularly psychological symptoms of the menopause. And this is talking therapy, which really helps challenge the behaviors and thoughts attached to feelings and mood. And that it's learning a technique to help break the vicious cycles that you talked about so well earlier, Sally. Antidepressants, I'm going to come back to, because there is good evidence that if your mood symptoms are related to the menopause and the menopause transition, totally acknowledging how difficult it can be to tease out whether it is or not, HRT and giving the estrogen back can be more effective than giving antidepressants. We know lots and lots of women get given antidepressants by GPs when they present with these symptoms that I read out at the beginning that can be related to the menopause. And, you know, for some women, they will help take the edge off. And if women don't want to take HRT, if they've been advised not to take HRT, antidepressants, accepting the limitations and side effects can have a role to play. And if you do suffer from major depression, you know, if you have really dreadful depression that is affecting function, then antidepressants actually have a really important place to play. But if your mood symptoms are menopause, hormone related, then hormone replacement therapy is probably the most effective option.
Yeah, and just to touch on, because I can see questions coming through and we'll come into those in a moment, around how depression relates to anxiety, and we know that's another common symptom of menopause, and is that often part of depression, or again, how might we approach that?
Yeah, so it's really interesting. So they can go hand in hand. They probably have the same root stem in your brain, and some people will be more prone to sink down the depression, low mood, feeling blue, and other people will be more prone to anxiety. And for some people, they can have a bit of both. The same process is going on biochemically to cause both symptoms. We know anxiety is also related more to swings of hormones that are going on in the menopause transition. And really, the management options, the treatment options are the same for both. So you sort of clump, as a doctor, we sort of clump them together, although obviously women's experience of them is very different and impacts in different ways.
Okay, brilliant, fantastic. Sarah, can I just bring you on, just so I can see we've got lots of questions coming through, just so we can start to cover some of these, and then we can revisit some of the key points to take away. So Sarah, over to you.
Thank you, Sally, and thank you, Dr. Clare. Yeah, there's been a number of questions coming through, and people have been sharing their stories as well, which is fantastic. I think you've been answering some around the HRT, Dr. Clare, and then somebody else was asking, you know, have you got any tips on how we can be less judgmental with ourselves? You know, you mentioned a moment ago, running works for you. You know, when you're suffering from those symptoms, any tips?
Oh, yes, it's because you immediately blame yourself, don't you? And feel this is your fault. This is a failing within yourself. You're not being strong enough. I hear women say, I'm trying to pull myself together so badly, but it's just not working. My biggest top tip would be appreciate this is beyond this is not within your control to some extent. The root cause is not within your control. The hormonal changes in your brain are the hormonal changes in your brain. It's going to happen. And then I think once you accept that, it's then looking to the positives to try and challenge those feelings. And you may need somebody else to help you to do that. You know, not everybody can do this themselves. And again, that's not a failing. It's just you need somebody to sort of guide you through challenging those negative thought processes, those negative vicious cycles that can get set up. So I really, my take-home message would be, if anything, don't look at it as a personal failing, please. Yeah.
And a lovely anonymous questions come in, Dr. Clare. Someone is saying, as a male in a woman-dominated office, how can I support my colleagues who may be going through menopause and are depression?
Yes. So I think from a personal point of view, it's educating yourself. It's understanding what might be going on for that person in your office, what's going on behind the scenes biochemically and hormonally that is manifesting in this way. It's being supportive, it's not being judgmental. And it's also thinking about the wider culture of the menopause, the wider sort of environment that you're working in. Is the menopause something that's openly spoken about? You know, are there places that you could maybe gently signpost, help her to notice that there may be a menopause cafe that in a sort of, you have to be careful. You don't want to sort of be pushing somebody there who doesn't appreciate that that's where they're at the moment. And that's why the sort of general environment and culture ethos of your company is so important. But arming yourself with facts and education to be able to be sympathetic and empathetic.
Yeah. And lots of people have been sharing what's worked for them. Somebody's mentioned CBT, someone else has mentioned meditation, self-compassion. A number of questions have come in regarding testosterone. I know there's been a lot of talk about this in the media recently, but any advice you can give with regard to this?
Yes, so testosterone is the sort of third important hormone that's made by the ovaries, and the levels slowly decrease from your 30s. And that seems to be really important for some women, but not for others. And one of the sort of main symptoms of low testosterone that we know about is loss of libido. And loss of libido also can be the sort of end point of all of those symptoms that we've spoken about low self-esteem, feeling low in energy, tired, etc. So the evidence is that testosterone can help with libido, and it probably helps about 2/3 of women who take it, so not everybody. In terms of mood, the evidence for testosterone actually helping anything else is really poor, but mainly because people just haven't done the studies. And so anecdotally, people will say that the testosterone was the sort of icing on the cake, the missing piece of the jigsaw after they'd started HRT and estrogen. If there's still a little bit lacking, they could still feel there was a bit missing. So the evidence for its use in depression is really poor, but it definitely helps a small percentage of women who take it. Some of it's converted to estrogen, so possibly helps in that way. And then there are other pathways that it can have positive effects through.
And linked to that, a number of folk are asking, how do we push this as an option with our GPs? They're obviously struggling to get testosterone from their GP.
Yes, and the issue is it's not a licensed medication for women in this country. So when a GP tries to prescribe it, usually a warning will flag up on their computer screen saying for specialist initiation only. So often GPs, more often than not, aren't comfortable prescribing off license, and there is this warning. Increasing, so CCGs, clinical commissioning groups, are looking at this. We certainly are in my area, and there are some parts of the country now where GPs are allowed to initiate it. In terms of pushing for it, really, if your GP is not comfortable prescribing it, then asking for a referral to a menopause clinic or a menopause specialist. In some areas, there will be a specialist menopause clinic. In other areas, the menopause care is done by gynecologists if a referral is needed. So I would go back and ask for a referral if you're not getting it from your GP.
Fantastic, thank you.
Yeah, I've got a couple of questions that I've just seen come through around the fluctuation in hormone levels and whether that can be, is it almost like on a daily basis, and can that be an indication where people are maybe feeling good some days and a real low mood and feeling very depressed other days? Could that be more an indication that it's hormones as opposed to that persistent low mood?
Yes, that's a really good question and an excellent comment. Completely, because yes, when your estrogen is at a good level, you can feel really great, and then it drops and you just feel terrible. Progesterone probably has a part to play as well. Some women are really sensitive to progesterones, and that's partly responsible for premenstrual symptoms. And that can be really challenging for women who want to take HRT in the menopause, but a small percentage of women are super sensitive to progesterone and will say things like, when I'm taking the progesterone, I feel like a dark cloud has ascended over my head, feeling blue. Some women saying, by the end of their progesterone days, if they're taking it for half the month, they even feel suicidal. It can have a really profound effect. And then the challenge is because progesterone is important to keep the womb lining thin, which estrogen can thicken. And the challenge is then really working with your doctor through different options to see if you can find a form of progesterone that you can take. So going back, yes, swings of estrogen, good estrogen feel great for some women, low feel low. For some women, it's the changes and the increases in progesterone as well. For some women, it's the HRT progesterone that just really has an impact. So it's lots of different factors coming into play.
Yeah, and I think that's where it's really complicated, isn't it, to be able to work out what's going on for you and then what is the right thing. And it's not a one size fits all, and it can take time to find that.
It absolutely can. And yeah, sometimes HRT doesn't give you the whole answer either. You know, sometimes looking to other therapies as well as HRT is what is needed to just try and sort out all the different bits of it and deal with everything that's going on for certain women. Yeah.
And someone's asked around serotonin tablets, whether they can be supportive.
So serotonin itself isn't something that I'm aware of as being available directly on prescription. So if it's an alternative therapy, it will be that there's not very much evidence surrounding efficacy or safety. Certainly, most of the antidepressants that are prescribed now in primary care as a GP are what we call selective serotonin reuptake inhibitors, SSRIs. And that is how they work. They stop the serotonin that's being released, being gobbled up and broken down by cells to keep the serotonin levels in your brain buoyant.
Yeah, absolutely. Sarah, have we got any other questions?
Yeah, a number of people have been asking some questions around their estrogen levels, Dr. Clare, and saying, you know, how do you know if you've got the right level? Because it differs with patches. And related to that, can you make any comment about the latest HRT shortages as well? Because there have been a few questions on that.
Yes, yeah. So estrogen levels, it's a tricky beast. So there is really poor linking between what the actual estrogen level number is and how you're feeling. So estrogen levels are really helpful if you, as a doctor, suspect that somebody isn't absorbing very well from their HRT. So whether it's a patch or gel or spray and they're just not feeling better, they can be really useful then. But once you're sort of within a wide, what we call therapeutic range, once the estrogen level is where you would expect it to be if the estrogen was being absorbed, it's really difficult to link how high it is and how good you're feeling. And some women actually feel worse when their estrogen levels are at the higher end of that range, which is interesting. Yeah. So estrogen levels aren't simple, you know, and in the perimenopause, even if you're on HRT, your estrogen will still go up and down a little bit. So, you know, you can still have high one day and lower the next. So that all just needs bearing in mind when you're thinking about checking your estrogen. In terms of the HRT shortages, it's been a real nightmare. It hasn't it? And caused so much anxiety and stress. Women worried that they're not able to get their HRT, which is keeping them buoyant and functioning. So the issue was around estrogel primarily. That's the Besan estrogel, which the supplies just ran low. Use was far greater than the supply. Besan have said that they've just poured loads of resources into getting this back. And I am hearing fewer people saying that they can't get it now. Estrogel, 1 pump of this is equivalent to a 0.5 milligram little sachet of Sandrina. So switching to Sandrina can be helpful and you sort of adjust the dose accordingly. 1 pump of this is equivalent to a 25 microgram patch. So switching to patches has been a good option for some women, although then the knock-on effect there's been a shortage in some patches as well. And also some women then switch to Lenzetto, which again, in my area, there's been a massive shortage. I haven't been able to get any Lenzetto. It's really tricky. It's been patchy around the country. Hopefully it's resolving. and just getting advice from your doctor about what to switch to is the best way forward.
Yeah, and just on that, someone said as well, just what you were going back to around progesterone, saying that their doctor had suggested stopping taking progesterone orally because they were struggling exactly with what you talked about, those feelings of depression, and taking it vaginally, and they said that made a big difference to them.
Yeah, that's really interesting. So if you swallow progesterone capsules orally, the breakdown products from your stomach can affect your brain and affect the mood. And if you put the capsule into the vagina, or you use the progesterone pessaries, it's not broken down in quite the same way. And so it can have a lesser impact on mood than swallowing it. It's not licensed for use in that way. And there is evidence that it does what it's meant to do in keeping the womb lining thin and stable, but it's more limited evidence than swallowing it. So you just have to bear that in mind. But no, absolutely can be better tolerated.
Absolutely. I can see a lot of people are asking around the names of those things. We will, after this session, we'll share the recording and also an article which have all of those details. And we've also got some signposting around equivalence around HRT, so we'll make sure we share that with people joining today. Sarah, any final questions? I know we've got lots coming in, but anything else that we wanted to cover off?
Got a huge amount coming in, and thank you for submitting your questions, and thank you for submitting your sharing as well. There's lots of lovely sharing going on in the chat, Dr. Clare, which I think is really important as well for people to share their stories. And lots around, how they're suffering, and how they're suffering in perimenopause. And if you know you're in perimenopause and having those symptoms that you described earlier, that persistent feeling of worthlessness and feeling guilty. So thank you for sharing that. People are talking about all of the current information on HRT out there at the moment is that it has some great health benefits, but someone's asking, is it advisable to take HRT at the age of 56, even though I'm not recognizing those typical menopausal symptoms now?
It's a really difficult question to answer. The British Menopause Society, the International Menopause Society, don't recommend HRT purely 100% for the health benefits or for health prevention in the absence of symptoms. And that's because of that really small increased risk of breast cancer. We know from many types of HRT that is related to the time that you spend on HRT. But it's really difficult because we know that the benefits outweigh those very small risks. And the benefits to the cardiovascular system, so in preventing heart disease related deaths, in preventing osteoporosis. The evidence surrounding dementia is a little bit more complicated. It's likely to be very beneficial to younger women, early and much younger women in the menopause transition than older women. Not that 56 is old by any stretch of the imagination, but going through the menopause at a sort of average age. So I think it really is an individual decision. It's an individual discussion with your doctor about what are your risk factors for osteoporosis, what are the risk factors for heart disease, how could it be beneficial to you. It's tricky, it's difficult.
It really is. Thank you. I think we just got final couple of questions. I've got one. I think Sally's got one as well.
Do you want to go ahead?
Yeah, so someone was asking around the risk, Dr. Clare, if our mothers suffered with depression during menopause, is that likely to happen to that individual as well?
So there is a genetic element to depression. And there is probably a bit of a genetic element to how you experience the menopause, but it's only a tiny part of it. And when you consider that over 50% of women will experience some form of depressive symptoms as they go through the menopause, it's so common, it's difficult to sort of generalize whether it runs in families or not. Yeah.
Fantastic. Well, thank you all very much. One of the comments that came through, very much reflecting what Claire was saying, someone shared the Samaritans number. So absolutely, if there is anyone that you know that is feeling those suicidal or really depressive thoughts, please don't be struggling and suffering. Reach out, whether it's your GP, crisis line, Samaritans. please make sure you're talking to somebody so that you're getting the help and support you need around this, because I think that's a really important thing to leave with, isn't it, Claire?
Yes, and I would really reiterate that, you know, it's very easy to feel like closeting yourself off. You don't want to talk to anybody, you don't want to go out, but there is so much help just poised, waiting for you if you are having those horrible suicidal thoughts, suicidal ideation. Please reach out and ask for help.
So thank you all very much. Thank you, Dr. Clare, again for joining us. Really appreciate your time. Thank you, Sarah, for the questions, and for everyone for joining in, sharing your experiences and asking the questions. We really appreciate it. And we look forward to seeing you on the next session, and we will share the resources and recording following the session. So thank you all very much and have a lovely rest of the day.